Now, on to our first speaker. I think there's a sense about this meeting, which is why it's such a huge, great sense to be here, that we've got evidence royalty in the room. And I think perhaps the most royal of the royals is Jack Wennberg, who is the father of clinical variation, of looking at why there's variation in practice and helping us to try to understand which bits of that variation are justified and which bits are not. So I'm extremely grateful to Jack Wennberg for being here and look forward very much to hearing him talk.
Well, thank you. It's a great pleasure for me to be here and asked to identify what's needed and what's not needed in healthcare, which is always an impossible task, but I'll try anyway. And basically, the strategy that we've been using is to take the general tools of epidemiology and apply it to the healthcare system itself, so that the way that services are delivered becomes the goal of our epidemiology. And in the process of that services, we've been able to look at healthcare in a sort of a new way. The question is, what is the impact of healthcare on the populations? Make sure I get this. Yeah, here we go. So I was asked to address whether better care costs less. And as you'll see as I go ahead here, it's never a simple question. It can cost less in many examples, but can we actually achieve those savings itself becomes perhaps the most fundamental question. Now, the way we've we've structured our analyses is to begin with the smallest unit we can, the zip code, and to ask the question, where do people who live in this particular postal code go to get their health care? And from that fundamental analysis, we build up a matrix which allows us to assign zip codes to specific care institutions, hospitals in this case, and to subscribe around these zip codes space and territory where most of the services are given by the local hospital. The second step then is to take these local hospital service areas, of which in the United States we've found some 3,500, and to aggregate them into regions based empirically on where people go for neurosurgical procedures and for cardiovascular procedures, which was our empirical criteria of regionalization. And on the basis of that, build up some 306 geographically distinct regions around the United States, which you can see on this map. And remembering as you look at the information that comes out at this level of aggregation, that what we're seeing at the regional level is the weighted average of the performance of the individual hospital service areas that are aggregated into this area. Now, given that quick background, I want to begin with the overview of what we have seen over so many years, and that is that medical practice occurs within a local context. The per capita expenditures, the resource inputs, the number of physicians, labor, the numbers of hospital beds, the number of nursing home beds, et cetera, and the actual utilization rates, the amount of surgery performed, the number of hospitalizations for medical conditions, varies extensively among these larger regions, among the hospital service areas, and even and more directly among the actual constituent healthcare organizations that are in these regions. Much of this variation can be called unwarranted. It simply can't be explained or hasn't been explained. It couldn't, in theory, be explained by illness, evidence-based medicine, or patient preferences. And the today I'll be looking a little bit about the challenge to evidence-based medicine of the practice variations. And that challenge is geared around this final comment on this slide, namely that the causes and the remedies, what to do about unwarranted variation, differs according to the category of care. Now, what do I mean by the category of care? Well, simply this. As we look at variation, certain things clearly are being underused, and they're being underused based on the criteria that has been produced by evidence-based medicine. Namely, for people with a given condition, the service is effective and the risks are minimal. The decision to use the drug or the service or the intervention generally should be based on that criteria, and underuse is the major problem with effective care. Now, supply-sensitive care and preference-sensitive care are the other two categories I'm going to be talking about, and they may seem a little strange and odd to you because we usually don't talk about health care in those dimensions. I'm going to talk first about supply-sensitive care, but just to keep you anticipating what the preference-sensitive care issues, they basically involve such things as elective surgery where there is a choice of treatment, surgery, or other methodology, and where under normative circumstances the decision, since it involves the patient's preferences, should belong with the patient. Now, the supply-sensitive care issue, first of all, let me define what we mean by this, and basically these are everyday services provided mainly to patients with medical, that is to say, non-surgical conditions. There's physician visits, referrals to specialists, MRIs, laboratory tests, screening exams, hospitalizations, and stays in intensive care units. What's at issue here is the frequency of use, the intensity of use of these kinds of services, particularly in managing chronic illness, where we raise the question, given the variation that we see, which rate is the right rate? And supply-sensitive care accounts, this is why it's so important, at least in the United States, it accounts for most of the twofold variation in Medicare spending among the regions that I put on that slide, is correlated highly with supply-sensitive care, and peculiarly isn't correlated at all with surgical care. So if you're going after the money, you've got to pay attention to this particular category. Now, I want to start out by demonstrating or reviewing one of the earlier studies we did in which we compared what was happening to people who live in Boston and people who live in New Haven. And why am I interested in these communities? Well, they are the best in the world, and each is better than the other according to local lore. And the vast majority of the services in both of these communities are delivered by very well-known academic medical centers. Yale New Haven Hospital in the case of New Haven, Harvard, Boston University, and Tufts in the case of Boston. So we can't complain that this is backward medicine. This is medicine that's not informed by the conventional wisdom associated with academic medicine. Now, what we see historically is that for reasons that have nothing to do, as far as I can tell, with illness differences or objective functions about why, Boston just has simply built more hospital beds and hired more people and has more doctors by a striking factor compared to New Haven. Now, why this happened, I won't spend time on, but let me say that it requires sort of shoe level intervention from the epidemiologist. You have to go knock on doors and reconstruct the history of constructions of hospitals and why did they do it. And generally in Boston, it was to keep up with the other medical schools. And that was a clear motivation that we could see. So the question is, how are these services used? For what are they allocated? And what we can see immediately, if we compare one community to another, is that Boston consistently uses more hospital days or more hospital discharges across a host of chronic illnesses. It's not just one, But it's all of them. And it turns out to be about a constant ratio of 1.6, miraculously about the same constant ratio as the number of beds available. And the occupancy beds in these places are always the same, they're always full. So almost by deduction, one says that this is somehow associated with the overall capacity of the system. Now, the interesting, sorry, I just want to spend one more minute on this slide here. The interesting thing is that in trying to get at the causal pattern or the causal vectors behind this, I actually conducted interviews with physicians in both Boston and New Haven prior to publication of the data. And I did not, in the tradition of Archie Cochran, I did not label which area was which, simply to get all the theories out on the table. And it turned out that there was almost no understanding or recognition that there was even a difference in the utilization rates between these communities, much less which was higher. And I could see that not just in people who'd lived in these communities over the life of their professional life, but also among those who'd migrated. People from Boston who'd moved to New Haven were unaware that their practice patterns were changing to the degree which they were. So this phenomenon of the association between capacity and utilization for medical admissions is not just a Boston, New Haven phenomenon. Here you see the association between beds along the horizontal axis and utilization vertical. And for hip fracture, there's basically no relationship. Hip fracture is a really interesting condition because it is not variable beyond what seems to be a reasonable estimate of what the illness rates are. And if you think about it for a moment, all hip fractures get to the doctor unless they have some death on the way. Easy to diagnose, and I don't know, even in the United States, with all of its underinsurance, we still don't put people with hip fractures back on the street. We hospitalize them. So the hospitalization rate itself becomes a surrogate for the incidence. Not so for the vast majority of medical conditions. Also, the association between the numbers of physicians. Here we see cardiologists, and on the vertical line we see visits. Now that's not strange. If you have twice as many cardiologists per capita, they all work 40 hours a week, you should have twice as many visits. In the case of the cardiologists, because there's a limited supply of people with cardiovascular disease, this phenomenon takes place in terms of the readjustment of the interval between revisits. So you see many more revisits over a given period of time in high-rate regions compared to low-rate regions. The intensity of this physician visit issue, this is a figure which, Fee, you may recognize because you published it many years ago, showing the differences between the visits during the last 6 months of life for some fairly well-known academic medical centers. And I draw your attention to NYU, where we see 76 visits to physicians for patients who are using that institution during the last 6 months of life. These are patients all with chronic illness. Compared to the Mayo Clinic, which is at the other end of the spectrum, which uses less than 23 visits compared to 76. Now that is giving you sort of a sense of what is tolerable in terms of practice variation, in terms of allocation of resources for managing chronically ill patients in the United States, first-rate academic medical centers. So what we can say is that clinical science isn't doing very much for us in terms of trying to manage resources and otherwise convert resources into care in a cost-effective way. Now, can better care cost less? For supply-sensitive care, it's clear that it does. In the United States, organized systems such as the Mayo Clinic and Intermountain Healthcare are typically located in low-cost regions. They manage chronic illness more conservatively and with lower per capita costs, and do well in terms of quality and patient experience. And benchmarks that are based on risk-adjusted utilization rates in these regions suggest a savings about 30% or more for supply-sensitive care across the United States, which is no mean number. Now, going from the realization that these benchmarks predict such savings to actually achieving savings means downsizing enormously powerful institutions, interrupting physician careers, and otherwise causing chaos, and more chaos than we already have in the U.S. healthcare system. So this is what is going to be one of the big struggles, I think, in our country, is going to be the question about, if we have so overinvested in the acute care hospital sector, how do we reallocate those resources to more effective purposes? And if one begins to tie that into our budgeting problems in the United States, where the allocation and opportunity costs are associated not just with healthcare, but with the school systems and roads, et cetera, you have the building dilemma of quite a drama that's going to take place, I think, in the U.S. Now, let me turn, how much time do I have left? 5 minutes? I can do this one. Preference-sensitive care. These probably involve trade-offs. More than one treatment exists and the outcomes are different. This would be lumpectomy versus mastectomy. It would be knee replacement versus conservative management. Any of these questions where patient preferences come into play, and where we have very good evidence, most of it conventional wisdom, but nevertheless, some clinical trials are showing that you can, in fact, liberate the patient to make choices by actively giving information and decision aids. So the problem is that provider opinion often determines which rate is right. Now let me just run through again Boston, New Haven very quickly to show you, in contrast to supply-sensitive care where Boston was always high, here you see the idiosyncratic nature, namely for knee replacements and hip replacements. Boston is much higher than New Haven, whereas for coronary bypass surgery and hysterectomies, it's much lower. This is the classic surgical signature we talk about in our epidemiology. Let me just go quickly through knee replacement and to show you that we've had a constant increase in knee replacements. Each of these dots is one of those 306 regions I've shown you. And you can see the national average is creeping up from 4 to 8, doubling over the period of time that we've been observing it here. But we see absolutely no regression to the mean. We see regions that were high stay high, regions that were low stay low. And if we ask questions about apparent quality, some of our best regions, Intermountain Healthcare, Mayo Clinic's regions, are at the high end on this. Some of our best regions are at the low. Dartmouth region, for example, Mayo Clinic, Geisinger Clinic. So it's basically not a problem clearly associated with willful induction of utilization. And this is the key paper for understanding that. It's Gillian Hawkers went out to actually interview a random sample of patients in the Canadian province of Ontario using the Wolmar score to find out all those patients who had a high arthritic pain flesh history, taking x-rays to find out who was eligible for knee replacement and hip replacement, and then introducing a decision aid, asking the question, do you want this procedure given where you stand? And this is the key and very important finding. Among the severely arthritic, no more than 15% were definitely willing to undergo hip and knee replacement at the time of this study. So in other words, the dictates of evidence-based medicine, classically understood, said operate on all these people. The preference issue said you're going to be operating on 5 out of 6 people who don't want the operation. In other words, wrong person surgery. So that's the critical message here, that if we don't get the patient involved in these decisions, our evidence-based medicine strategies will not lead to the rationalization of utilization in the way we think that they should. Now, how many more minutes? One? All right, I will just skip ahead to say that, because I want to get to this. By the way, the UK's got this problem in spades. This is just in case. But basically, I want to go through the challenge of practice variations to evidence-based medicine as I see them from the point of view of our research. First, the agenda needs to be expanded to focus on preference-sensitive and supply-sensitive care. Most of the work of evidence-based medicine is on effective care, things that are easy to are specific interventions in which utility and preferences are not foremost. Familiar tasks, testing, hypothesizing concerning new or established clinical theories. There's always evolving theories. They always need to have the work of evidence-based medicine. But not so familiar is the evaluation issues around patient communication, patient preferences, and decision quality. Decision quality, by that I mean the measurement of the decision to make sure the patient A, understood what was at risk, and B, were those choices of treatment commensurate with the underlying preference structure of that patient. Complicated issues, but key if we're going to get to the bottom of this practice variation issue. Unfamiliar, evaluating the effects of capacity and other supply influences on clinical decision-making. And finally, constructing longitudinal clinical pathways for managing chronic illness. All of the chronic illness management in the United States, even in some of our best places, is essentially chaotic. It is not longitudinal. It does not involve defined, testable protocols about how to manage care over time. So that's it.